So we're going to talk about VTEs. I think we would all agree that this is still a serious problem within our specialty, so I'm going to provide some data. I have no relevant disclosures for this presentation. And we all know why patients potentially can die after bariatric surgery. It's leaks, bleeding, and VTEs. Probably most lethal of those three is the VTE category. So I'll share with you some of the work my partner Ali Aminian has done, and it really boils down to where should we be focusing our quality improvement efforts. So this is a really innovative way to look at the data, and we used the MBSA-QIP just recently put out a participant use file. So for the year 2015, all that data is available to the public. You just can download the data, and you can mine that data for whatever research question that you want to ask. And so if you come to Obesity Week, you'll see lots of MBSA-QIP abstracts and presentations, and every year we'll then produce a new participant use file. So this is one of the things we're offering out of that quality database. So we got the PUF, and Ali went to work on it, and what he did was a really innovative way to look at what complications result in which outcomes, and he did a statistical analysis determining the impact of 8 different complications on 6 variable outcomes, and he did these risk-adjusted population-attributed factor pairings between a complication and an outcome. And you can see the complications that were evaluated there: bleeding, VTE, leak, etc. And the outcomes, of course, were multi-organ failure, reintervention, reoperation, a trip to the ICU, readmission, and mortality. So the data set was 135,000 patients. You can see the procedure distribution there is pretty typical of what we're seeing in the United States right now, which is 67% sleeve gastrectomy, about a third gastric bypass, a few bands and DSs. And you can see the complication rates there are all generally pretty low. Bleeding, they're all less than 1%, 0.7, surgical site infections, 0.5. UTIs 0.3, and the VTE rate in this particular year was 0.3%. When he did these pairings between the complication and the outcome, the complication that had the greatest impact on readmission and mortality was the VTE complication. And so he went back and validated this with another data set using about 20,000 patients from the American College of Surgeons NSQIP data set, which is a more general surgery, but it has a bariatric component in it as well. And he used it to validate this data, but essentially using that data set, using 91,000 patients, again with primary and revisional bariatric surgery over a 5-year period, we were able to really develop a calculator. So using all these variables, we were able to do a regression analysis, and I'll share those with you here. And ultimately, Ali was able to develop an online risk calculator. It's something that we use every day in our office now. And you can see in this particular data set from NSQIP, you can see the incidence or the occurrence of VTEs in the postoperative period, with the vast majority of them occurring after hospital discharge. Out of the 92,000 patients in this cohort, there were 269 VTE events, and this is our univariate analysis. But when we did the multivariate analysis, several things fell out in the analysis, and most significantly, the history of congestive heart failure really was the greatest predictor of having a VTE event, with an odds ratio of nearly 14 times the comparator group. Paraplegia and immobility clearly drives VTEs. Complications requiring reoperations, returns to the operating room, again, probably result in a delay in prophylaxis and certainly more immobility. Dyspnea at rest and pulmonary issues, stapling procedures, and you can see on down the list, length of stay, length of the operation, as well as male gender. These were all predictors of VTE based on this analysis. And so we basically broke this down into 3 categories. The most sensitive cutoff points were 0.4% and 1%. So if a patient had a risk based on this calculator, you can plug in these 10 variables. It spits out a number of what that patient's potential risk is. And if it's less than 0.4, then they fall into the average risk category, and they get what we would consider standard prophylaxis, mechanical prophylaxis, and chemoprophylaxis while they're in the hospital, and we use Lovenox in our center. If they fall in that category between 0.4 and 1%, then they're in that high-risk category. And there was about 20% of the population that fell into that high-risk category. Or if they have some, in addition to the calculator, if they have a history of hypercoagulable state or severe chronic venous insufficiency, we put them in that category. And those patients we offer or prescribe an additional 2 weeks of post-discharge chemoprophylaxis. Again, we use Lovenox twice a day in our patients. And for those patients who, based on this calculator, have a risk greater than 1%, we give them 1 month of extended prophylaxis using Lovenox. And of this population, about 2.5% of this study group fell into that very high-risk category. And so we do this in our pre-op visits. We plug these variables into the calculator. We get a number, we put it in our pre-op note, and that drives the discussion with the patient where their risk is in terms of their post-op risk of VTE, and it also helps us explain why we're giving them 2 or 4 weeks of shots to take after they go home. And it's been quite valuable, and it really has reduced the variability in our practice in terms of who gets post-discharge prophylaxis, and it's been quite valuable. So in terms of Ali's studies, the overall 30-day incidence of post-discharge VT was about 0.3%, and that's typically what we're seeing now these days. But about 80% of them occurred after hospitalization discharge. And those experiencing a post-discharge VTE, the mortality was nearly 30 times higher than those that didn't. So we know this is a highly lethal event, and the statistics bear that out. Of all the 45 examined variables in his analysis, the final risk assessment model contained those 10 categorical variables that we put in our calculator, which comprises about 2.5% of that population. And again, you can see the list of the predictors are mainly led by congestive heart failure and immobility as well as reoperation. And so we consider routine post-discharge pharmacoprophylaxis, certainly in those high-risk and the moderate-risk groups. And this calculator's online. If you basically search online for Cleveland Clinic risk calculators, there's a bunch of them, and there's 3 that Ali has developed, one for metabolic improvement, one for risk after sleeve gastrectomy, and one for VTE, and they're open to anybody who wants to incorporate them into their practice. Another data set from France looked at 110,000 patients assessing the incidence, risk factors, and impact of post-hospital discharge chemoprophylaxis on VTE patients undergoing bariatric surgery. And this is a national observational registry. So these were all patients who had bariatric surgery between 2012 and 2014. They did their logistical regression analysis to compute odds ratios for different risk factors going out to 90 days. We limited our analysis to 30 days, and this goes out to 90, which I think is helpful and sheds a little more light on the risk. And then they looked at the association between giving post-hospital discharge chemoprophylaxis and VTE. So, and the majority of the patients in this study, about 56%, had sleeve gastrectomy patients, and the rates at 30 days, similar to what ours is, 0.3%. But interestingly, you go out to 90 days, you add a couple 0.2% to that initial early complication rate to its 0.5% at 90 days. So I think it's important we continue to watch for these beyond the 1 month. On their multivariate analysis, the major risk factors in the first 90 days were history of VTE, hypercoagulable state, postoperative complications, similar to what we found, heart failure, interestingly, not quite as strong a predictor as our model, but still in the list, open surgery, and then in that study, 75% of the patients received post-discharge chemoprophylaxis, which I think is fairly high and fairly aggressive, which is a good thing. I don't think 75% of the patients in the United States are getting post-discharge prophylaxis. I'd be really surprised if it was even 50%. And they found that not using that post-discharge prophylaxis was actually a predictor of having a VTE with an odds ratio of 1.5. So folks that didn't get that extended prophylaxis were 1.5 times more likely to get a VTE once they got home. So this national study shows that although it's a fairly low number, it's non-negligible. It's 0.3 to 0.5% highly morbid events, and that post-hospital discharge chemoprophylaxis should be able to decrease the risk of post-hospital discharge VTE. Looking at the German surgery registry, they did a similar analysis. They looked at a prospective multi-center study, and they looked at the type, regimen, and time course of the prophylaxis regimens that were used, and then they looked at the incidence of diagnosed VTEs and PEs during the follow-up period. And this had 32,000 patients in it between 2005 and 2013. You can see the procedure spread there. It was mostly gastric bypasses, about 14,000 bypasses, 12,000 sleeves, and 4,000 bands. And most of the patients received Lovenox in this series, in this registry, over this time period. Overall, the DVT rate was quite low, less than 0.3, which we've seen in these other studies. So an order of magnitude less than that, at 0.07, with a PE rate of 0.1. So quite good results in terms of low complication rates there. But again, these are highly morbid and fatal events. So 5 patients died who had either a DVT or a PE within 30 days. So it's certainly something that's best avoided. And they found that age, BMI, male gender, and history of VTE were the strongest predictors of VTE in the German registry. So in summary, I think the answer is yes, VTE remains a life-threatening complication after bariatric surgery. It's something that we have to continue to assess how to prevent. Certainly our next, after I'm done with my enhanced recovery project with MBSA equip, we've decided the next national quality improvement project is going to be focusing on VTE, using our registry and running a national project to really get our arms around what kind of prophylaxis we should be recommending and in which patient. There's basically universal acceptance of mechanical prophylaxis and some form of chemical prophylaxis, but the issue of extended prophylaxis, I think, is still unanswered, and who should be getting it. So our recommendation now is to be liberal in the use of extended post-discharge prophylaxis for those high-risk patients. We have calculators available to use if that helps guide your practice. Some people are using anti-10A levels. I didn't go into detail about that in this talk, but we're also presenting some data at Obesity Week about what percentage of patients are actually not actually getting a prophylactic level using standard dosing with Lovenox. So there's ways you can be more granular about this, but for now I think we need more data to guide us in terms of our post-discharge prophylaxis. Thank you very much.